This lecture is about joints or articulations, and an articulation is where two or more bones meet. Functions of joints: they give the skeleton mobility and also hold the skeleton together. Functional classification of joints based on how much movement is allowed. We have three classifications: synarthrosis, that's immovable; amphiarthrosis, slightly movable; diarthrosis, freely movable. Okay, we also classify them based on the structure and whether or not they have a joint cavity. So we have fibrous, cartilaginous, and synovial. We'll have examples of all of these. Fibrous joints are joined by dense fibrous connective tissue, no joint cavity, and most are immovable. Examples: sutures, syndesmosis, and gomphosis. A suture, as you probably know, is joints that allow the skull, that join the bones of the skull together and allow growth in babies and young people. These are originally cartilage and fibrous connective tissue, and they eventually fuse when you're an adult. Now, syndesmosis, they're connected by ligaments, and they may be immovable or slightly movable. Example here is the distal joint between the tibia and fibula. It's held together by a ligament here, and it should not move. If it does, it's probably going to break something. Gomphosis, most people don't think about a tooth as being a joint, but it actually is. It's a peg and socket joint called a gomphosis. And the tooth, here's your enamel out here, your dentin, this is your root canal, and you have a periodontal ligament here that holds the tooth to the bone. And then here you have your gingiva, which is actually the gum, and the periodontal ligament securely holds the tooth in forever, hopefully. But if you get plaque and gunk and germs and such on your teeth and you don't take care of them, then you can finally get invasion here of plaque and bacteria just under the gum line, and then you get infection of the periodontal ligament, and you can start getting erosion of bone, and your tooth will fall out. Another issue on this is rotting teeth tend to lead to heart attacks and strokes, because every time you take a bite of food, bacteria from that rotten tooth gets into your bloodstream, because it always causes a little bleeding around the gum line, and you just seed your bloodstream with germs. Okay, cartilaginous joints. We have two types. Again, no joint cavity: synchondrosis and symphysis. Synchondrosis is a bar or plate of hyaline cartilage uniting bone. And this is an example. Your epiphyseal plate, your growth plate, is actually a temporary joint. And here's your manubrium of your sternum, and this is the first rib. So this cartilage here actually forms a temporary joint. Well, a permanent joint. I'm sorry, I said it wrong. Okay, cartilaginous joints, symphysis, and these tend to be slightly flexible. Pubic symphysis, it becomes flexible when a female is ready to give birth. Now, I need to probably have put a picture in here of a male versus a female pelvis. A male pelvis has very steep and narrow, this is supposed to be here, very steep and narrow, and my picture's not so good, but this is a female pelvis, and it allows the more room across here for babies to come through, and then this will eventually soften up as the baby comes out. Also, your intervertebral discs are basically a symphysis because you have hyaline cartilage and fibrocartilaginous material here, and then inside this you have your pulpous nucleosis. Okay, synovial joints. They're all movable or diarthrotic. That includes limb joints, most joints of the body. They all have articular cartilage, which is made of hyaline cartilage. It's just basically leftover ends from where the bone was originally made of hyaline cartilage in the embryo and the early fetus. The joint cavity is a potential space. It's also called synovial cavity. They all have an articular or joint capsule, 2 layers, outer fibrous capsule of dense, irregular connective tissue, and an inner synovial membrane of loose connective tissue. Synovial fluid. This is viscous, slippery filtrate, just made of plasma from the bloodstream, and then hyaluronic acid. And this lubricates and nourishes the articular cartilage. Now, when one exercises and you before the exercise, it's causing this hyaluronic acid to make the joint more slippery. It's like warming up melts butter. Well, it melts or softens that fluid and makes the joint less likely to be injured. So stretching, walking a little before you run can protect your joints by melting the butter or the hyaluronic acid. Now, this actual hyaluronic acid or hyaluronate, either way you want to word it, is actually injected into joints in certain instances to replace the hyaluronic acid. This is just a typical generic joint. You have ligaments holding it together, joint cavity. This is the space with the synovial fluid. This is the end plate of the hyaline cartilage and periosteum of the bone right in here. Okay, synovial joints, they're going to have reinforcing ligaments, and they may be of any different 3 types. Capsular, also known as intrinsic, are actually part of the fibrous capsule. Extracapsular, or outside the capsular. Intercapsular, or deep to the capsule and covered by synovial membrane. Joints have a rich nerve and blood supply. Now, the actual cartilage in the joint does not, but the overall joint does. Now, this nerve fibers detect pain, injury, joint position, and stretch. Now, the position of where you are in space is called proprioception, as you'll learn later on in the neurological stuff. But joint position, let you know where you are. Also, capillary beds produce a filtrate. Okay, other things associated with joints, bursa. I don't know about you, but I know my granny said, I got bursitis. Well, she probably did. They're little flattened fibrous sacs lined with synovial fluid, and they act as ball bearings around joints where ligaments, skin, tendons, or bones could rub together. Now, here's an example. This is a coracoacromial ligament. This is a subacromial bursa. And so when you get movement here, it prevents this ligament from rubbing directly on this bone. You don't want it rubbing directly on the bone because it would not be a smooth, nice operation. A tendon sheath is much like a bursa, but it wraps completely around a tendon. Now, this is the tendon of the long head of the biceps brachii. Now, they show it in green here. They show it just going a little ways, but it actually would go as long as the tendon went. And it's basically wraps around this tendon, protects it, lets it move and slip nicely, so you get a good movement. Okay, stabilizing factors in joints. The shape of the joint is a relatively minor role. Ligaments is a relatively minor role. And then muscle tone can be very important, especially in the shoulder, knee, and arches of the foot. Okay, now when we talk about movement across joints, the muscle has got two things. You have to have an origin. This is attached to the invisible bone, and then the insertion, which is attached to the movable bone. So this muscle has to go across a joint or you would get no movement. And muscle contraction causes the insertion to move towards the origin. It's like when you take and you flex your elbow, moving your hand towards your face. The origin, which is towards the top of that arm, is going to be closer to the insertion, which is on your radius and ulna. Movements can also be across transverse, frontal, or sagittal planes. Okay, types, range of motion. We'll look at these visual movements. Okay, a gliding motion. These bones are just simply gliding across each other as you wave. This is in your carpal joints. That's one type of movement. Flexion. Here you have the joint here getting more narrow. Extension, she's lifting her head up. Hyperextension, she's overextending that joint. Some joints cannot be hyperextended without damage, but the neck and back can be. So here, she's flexing her back here, bending down, standing up straight to extend it, hyperextend it, moves it backwards here. Okay, this is another example of flexion. You see this, she picked her foot up and made this joint become less than it was. So we have an angle that is less here than it would be as she begins to extend it. And then here we have a completely different angle. That's just an unflexed, completely extended joint. And here we have of the shoulder flexing and extending, moving it back. Okay, abduction and adduction. When someone is abducted or taken away, when you add things together, you bring them towards the body. Circumduction is easy, you're going in circles. Rotation is easy. This reminds me of that movie, what was it, Carrie Out? One of those horror movies where the demon-possessed child goes around in circles, bling, bling, bling. You can only rotate your head around and around in circles once, then you're dead. Okay, now this is rotation, and basically along C1, C2 is where you rotate your neck. Lateral or medial rotation of the leg here. Okay, these are two special case types of positioning of the hand. When the hand is in a state of pronation, it's this way. The radius rotates over the ulna. When it's in a state of supination, the radius and ulna are parallel. Just think about when you supinate your hand, it will hold soup. If, on the other hand, you pronate it, all the soup falls out. So you wouldn't want to do that. So supination holds soup. Pronation does not. Okay, these are special examples again too. Dorsiflexion, that means towards the dorsal side, you're actually flexing this joint here. Plantar flexion, we're actually referring to the bottom of the foot, so it's moving it down. We did this in class and several people's ankles popped pretty nicely. Okay, these are special to the foot too. Inversion, moving your foot in. Eversion, E is for exit, moving it out. Okay, the mandible, we can move it forward, that's protraction. We can move it backwards, that's retraction. Elevation of the mandible is closing your mouth. Depression of the mandible, opening your mouth. So when you elevate, depress, elevate, depress, it's what we do when we talk too much. It's called flapping your jaws. Opposition of the thumb. This is unique to primates, monkeys, apes, and hominids, which the only living hominid is a human. Okay, plane joints. This is an intercarpal joint here, just a flat joint. Hinge joint, your elbow here. This is your trochlear notch. Trochlea, it's just a hinge that elbow can bend across. Pivotal joints, proximal radio-ulnar joint. You can sit there and see, you can pivot that joint. Condyloid joint is here between your metacarpus and your phalanx, so metacarpophalangeal joint. This is a saddle joint, carpometacarpal joint of the thumb. And this is supposed to look like a saddle, and this is supposed to look like a rider, but he left his legs out, so we'll draw him some legs here. Now you can see he's a rider. Let me draw him just legs. Oops, I lost my pencil. Here we go. Now, that's his feet. Now we have a rider. So that's why we call it a saddle joint. And that allows us to oppose our thumb. Okay, ball and socket joint. One is the shoulder joint. And let's see. This thing is changing slides radically and crazily. Okay, shoulder joint is one. We'll go through more. Okay, specific joints we're going to talk about. We start with our knee joint. This is a very complex, it's the largest, most complex joint of the body. It's 3 joints surrounded by a single joint cavity. The femoropatellar joint, think of femur gliding across the patella. And this allows knee flexion. And then the lateral and medial tibiofemoral joints. These are between the femoral condyles and the menisci, lateral and medial menisci. And these are cartilages of the tibia. You get flexion, extension, and a bit of rotation when the knee is partly flexed. Now here is a knee joint. You've got a lot of different things involved here. You can see your cruciate ligaments here, anterior, posterior. We've got, this is a one of the bellies of the quadriceps femoris here. This is the quadriceps femoris tendon that inserts on the patella, and then the patellar ligament, I'm trying to find where it's labeled here, anyway, right here. It goes down to the tibial tuberosity. Very complicated. You can see all these bursa, suprapatellar bursa, supracutaneous prepatellar bursa, deep infrapatellar bursa, so a lot of bursa. And we're going to look at some different angles of this joint. Okay, this is, they've removed the femur, and you can see this is anterior here. And these are the menisci. This is a meniscus here, meniscus here. And so one meniscus, 2 menisci. So we have the medial and lateral meniscus. And what they do is they pad and fill in and make that joint fit properly. Now here you see your posterior and anterior cruciate ligaments, and they prevent backwards to forwards movement. Also, there's at least 12 bursa. We have muscle tendons. Okay, the quadricep and semimembranosus tendons reinforce the joint. Joint capsule is thin and absent anteriorly. The quadriceps tendon also breaks off into the lateral and medial patellar retinacula and the patellar ligament. Here we have our quadriceps femoris here. This is the tendon of the quadriceps femoris. It's going to go down here to your patella, and then you got your patellar ligament here. Now, this is the lateral patellar retinaculum right here. This is the medial patellar retinaculum here. This is the fibular collateral ligament, can also be called the lateral collateral ligament because the fibula is always lateral. This is the tibial collateral ligament here. It can also be called the medial collateral ligament. Okay, slide. There we go. Okay, now we have ligaments. The cruciate ligaments prevent anterior to posterior displacement, and they are extracapsular. They're outside of the synovial cavity. They're covered by synovial fluid. So here we have our posterior cruciate and anterior cruciate, and here you can really see how the menisci work. Here's your condyles here, lateral and medial condyles of the femur. And you can see how this cruciate ligament neatly covers up, gives a surface for these condyles to rest. Now we also can again see our fibular or lateral collateral ligament and our tibial or medial collateral ligament here. Okay, this is a typical injury. We don't do so much hockey here, though. There's a team in Columbus and maybe one in Macon, so it is probably more common, but it's a typical football injury. A lateral hit to the knee joint, and this lateral collateral ligament may hold up, but the force inwards tends to break this tibial or medial collateral ligament, tends to destroy meniscus and the anterior cruciate ligament. It tends to be torn. Now, if you don't surgically go in and fix that anterior cruciate ligament, that person's life as far as an athlete is over. It requires surgical intervention. And we saw a video in class where they use a little retro flip cutter to make holes through here and through here, through the femur, through the tibia, and then they use either a cadaver ligament or part of a tendon of the person's own body to build a scaffold so that the anterior cruciate can be rejuvenated. Without surgery, they will have forwards, backwards movement. They will never have a stable joint. Now, another thing that's not mentioned here that causes joint stability or instability is the quadriceps femoris. It really needs to be extremely, why that highlighted? The quadriceps femoris muscle needs to have a lot of muscle tension in it. Okay, now the knee joint is the next one we're going to talk about. It has capsular and extracapsular ligaments. Oh, we were on the knee joint. This thing's totally crazy. It's just going everywhere. There we go. Now we're back. Shoulder joint. And I apologize, but I'm probably not going to do this over. Okay, ball and socket joint, the head of the humerus and the glenoid fossa of the scapula. And there's less stability than there is in other joints because you get more freedom of movement. So here is our glenoid cavity here. Here is our our glenoid cavity, and here is the head of the humerus. So this is our articulation. You can see we have the acromion and the coracoacromial ligament here, subacromial bursa, sheath. So there's a lot going on here in our shoulder. Has reinforcing ligaments, coracohumeral ligament and 3 glenohumeral ligaments. Okay, reinforcing muscles, and these are extremely important. The tendon of the long head of the biceps secures the humerus to the glenoid cavity. And then we have encircling the shoulder joint, the rotator cuff tendons, subscapularis, supraspinatus, infraspinatus, and teres minor. And when you hear people having rotator cuff surgery, they've had an injury that's damaged or stretched either the muscles or the tendons and have to be surgically fixed in many cases. Okay, the elbow joint, radius and ulna articulate with the humerus. So it's a hinge joint formed mainly by the trochlear notch of the ulna and the trochlea of the humerus. It's flexion and extension only. Now we have an annular ligament and two capsular ligaments that stop side-to-side movement, ulnar collateral ligament and radial collateral ligament. Okay, as you look here, we have the annular ligament. It goes all the way over from ulna across the radius. This is our radial collateral ligament here, olecranon process. And as you look on the other side, we have the ulnar collateral ligament. Again, we have our annular ligament. It goes all the way across here. And here's our articular capsule. The coxal joint or hip joint is a ball and socket joint. The head of the femur articulates with the acetabulum. And this is good range of motion, but it's limited by the deep socket. And the acetabular labrum enhances the depth of that socket. So here we have acetabular labrum. It's coming out a little further than you might expect. Here's our femur. Now this is something important. This is the ligament of the head of the femur. It's also called ligamentum teres. If the hip comes out of joint and you put the hip back in joint and fasten all these articular cartilages and any reinforcing cartilages, this ligament, as well as its arteries and veins and nerves, are going to be difficult to replace and put back in place. So the hip is going to come back out. So generally, if the hip is totally out of socket, it may be easier just to replace that hip, the head of the femur. And sometimes they replace the actual acetabulum. Okay, here we have, this is our ischium here. We have the iliofemoral ligament, ischiofemoral ligament here. That's the greater trochanter of our femur. Here we have our iliofemoral ligament. So from the ilium down to the femur. This is our pubofemoral ligament because this is the anterior portion here. So this is the pubis. So from the pubis down to the femur. Okay, another joint we're going to talk about is the temporomandibular joint, or TMJ. This is where the mandibular condyle articulates with the temporal bone. It has two things it can do. Hinge, which is depression and elevation of the mandible, and then gliding side to side. So it's for grinding your teeth, hopefully for food and not to annoy your sleeping partner. And this is easily dislocated, the most easily dislocated joint in the body. It can be put back in place and tend to stay there. Now, they've got the actual joint part covered up, but if it does disarticulate or come out of joint, what tends to happen is that the mandible moves forward so that the lower teeth are sitting somewhere out here. And, you know, there's no movement. It's an absolute devastating thing until it's put back in place. Very common for people who grind their teeth or have other issues to have inflammation in their temporomandibular joint. Okay, a few common injuries. A sprain, the ligaments are stretched or torn, and if it's just a partial tear, it may repair itself, but it takes a long time. Complete ruptures require surgery, or as your textbook says so eloquently, the ligaments will turn to mush. Cartilage tears may be due to compression, stress. Now, a thing that happens is, say, a meniscus tears. Fragments may break loose and lock the joint down. Cartilage is not going to repair itself, and you're going to have to do surgery, hopefully arthroscopic surgery. And this is an arthroscopic view of a knee with a torn meniscus here. Wish we had normal to compare it to. Okay, other common joint injuries, a dislocation or a luxation. Luxation, you have complete forcing out of alignment of the joint. Sprains, inflammation, the joint will be immobilized. Now, these are by falls, sports injuries. Subluxation is a partial dislocation of the joint. Okay, bursitis is inflammation of a bursa, often caused by a blow or friction. Overuse, they used to call some of the bursitis in the knees housemaid's knee, where apparently people used to get down on their hands and knees and scrub floors. I suppose somebody has been known to do that. Don't tend to do that. You treat it rice, rest, ice, elevation, anti-inflammatory drugs. I forgot what the things are on the rice right off. Rest, ice, compression, and elevation. And we have tendinitis is inflammation of tendon sheaths, and treatment similar to bursitis. Arthritis is caused by, there's many types, 100 different types, but it's degenerative disease that damages joints. It's the most widespread crippling disease in the U.S. Pain, stiffness, swelling of a joint. Acute forms are caused by bacteria and are treated with antibiotics. Some of the chronic forms we'll talk about: osteoarthritis, rheumatoid arthritis, and gout. Osteoarthritis is wear and tear arthritis. I hear a phone. 85% of all Americans develop osteoarthritis, and it's just wear and tear. Just ignore the phone. More cartilage is removed than replaced in badly aligned or overworked joints. Now, when we have poor alignment in a joint, it causes arthritis, and in animals we actually select for perfect alignment in joints, but we don't tend to do that in humans. You end up getting bone spurs, restricted ligaments, the ends of the bones enlarge. Treatment, activity, just stopping activity makes arthritis worse. Pain relievers, capsaicin creams, glucosamine, chondroitin sulfate are examples. Rheumatoid arthritis is a chronic inflammatory autoimmune disease. Usually arises between 40 and 50 years of age, can occur in children, more common in women. Joint pain, swelling, tends to be bilateral, it tends to be multiple joints. Anemia, osteoporosis, muscular weakness, and cardiovascular problems. Now, it starts with synovitis of the affected joints. You get inflammation. The synovial membranes causes a thickening or a pannus. It erodes the cartilage, scar tissue forms, and you get ankylosis or fusing of the joints. And this is an image of an osteoarthritic joint. A rheumatoid arthritis joint. You see, this is completely disarticulated. Okay, treatment: conservative, aspirin, other NSAIDs, antibiotics, which is kind of hard to understand if it's not caused by a bacteria. Physical therapy, progressive treatment, anti-inflammatory drugs, immunosuppressants. Now, anti-inflammatory drugs and immunosuppressants all have their side effects, which are something to consider. Okay, gout is due to deposit of uric acid crystals in a joint and soft tissue and inflammation. Now, you've got to have an already inflamed toe, an arthritic toe. I mean, it usually starts in the big toe. But you have to have an inflamed joint and an elevated uric acid level. If it's untreated, you end up getting immobilization and permanent damage to that joint. Treatment, there are drugs that lower uric acid. You have to stay hydrated. Avoid alcohol intake. Things that tend to increase the incidence of alcohol, which tends to explain to me why it's more common in men. Beer, sardines, fish, shellfish, beef, all the things that the men that I know love. Go fishing on the lake, take some beer, and then fry the fish. Okay, Lyme disease is caused by a bacteria spread by the bites of ticks. Now, they much talk about what kind of tick, but even though it tends to be just the Ixodes gene of ticks, there are several species and possibly even other genuses that can carry this disease. It's most common in the northeastern United States, very uncommon in Georgia, regardless of what the common press would tell you. You can get skin rash, flu-like symptoms. It can cause foggy thinking, joint pain, arthritis, can eventually cause heart disease, antibiotics. Now, it takes about 3 months for the test to show up positive. It's like AIDS or something, because what you're testing for is antibodies. So if you have a tick bite, and then you'll see this tick